Okay, I'm going to try to talk about what is roughly half my trauma cases, trauma volume in about 10 minutes. So let's just see if we can get through this. My disclosures are no financial conflicts. I do have a disclosure that I still use the Signal app in this country, and these are screenshots from today. I use it to support our friends and colleagues in Ukraine that are continuing to fight the good fight. So thanks for your indulgence in this. And we're just going to outline real quickly anatomic considerations. My task is to talk about when and how to fix the columns. So I'm going to introduce the columns, talk about some of the snakes in the grass, complications and risks we take with the midfoot injuries, and then tips and tricks, and then also some of the outcomes. And this is just enigmatic of polytrauma. We often have associated foot injuries that we might not be the life-threatening injuries, but they are often delayed because they're not as subtle, not as unsubtle as this one here. But just to understand the anatomy, the transverse arch, we all think about the longitudinal arch. Think about the transverse arch, which gives stability. And it's centered on this keystone, and that keystone is the second metatarsal to the middle cuneiform up into the talus, and that from which everything rolls and everything forces, all the forces are focused in that area. So when we look at the columns, they give us function. When our heel strikes, it needs to be flexible enough to absorb energy and accept the body weight, and then rapidly transition into a rigid lever arm. And it does that through the medial longitudinal arch, but that is all focused again into that center second ray with it. So we have a primary stability out of the medial column, and then the lateral column gives us flexibility or absorption with this. And so understand that the cuneiforms aren't just bones that are funny looking and have very little attachments. They're essential to convert this force into a torque that allows the lever arm of the Achilles to lift us up on our toes with this. And so it's the Lisfranc injury and Lisfranc structures are primarily ligamentous, but we understand that the mortise of that second metatarsal is about the only place where we really have any bony stability, and it's the keystone. Now, our feet are exposed to extreme forces. Every day, 4 to 5 times the body weight. Then we choose footwear that provides this kind of incredible forces onto a 2-centimeter size structure. It's much more potent and much more focused forces than we would see even in the knee or the pelvis injuries. So the medial column, as I've outlined, it starts with the talus, the navicular, and all of the cuneiforms into the middle or medial 3 metatarsals, and then the lateral column is more for flexibility. It's key to really recognize early in these. And one of the things to take home from this is that midfoot injuries that are unrecognized are short. They're a near second place to femur fractures as far as litigation sources. We have to understand open injuries and vascular injuries, but we have to be very, very respectful of soft tissue injuries. They are guarded in their prognosis because also from the delay and also from those extreme forces. The talonavicular joint serves as similar to an acetabulum of the foot. The high motion within this focused forces create problems when the talonavicular joint is disrupted on that medial column. And so rigid fixation and principles are important. And I just will talk just for a few minutes about our soft tissue considerations. We have to have plastic surgery. We have to have microvascular surgeons available first at the time of injury after debridements if they're open, or because there is very little soft tissue envelope around these, that timing we've talked about in other parts of the body, timing is very, very important in fixation. And so even at the time after surgery, it continues to be a problem. This is one of my patients. The skin actually necrosed after what we started with attempted non-operative treatment, but again, necrotic skin and some of the things that Ross talked about. So the medial column starts in the talus, but then you can have injuries progressively through the medial column that can disrupt that ability to stabilize the medial arch with it. And that's predominantly why we have to look at CT scans as part of our evaluation. This is not a subtle radiograph, but it is a column injury, as you can imagine, because the medial column is extruding that medial aspect of the navicular body with this. And so navicular fractures, there's avulsion types, there's a lot, and I'm not going to talk about those. Specifically, I want to talk about body fractures. There's a lot of classifications, not 143 like there are, the Prism talked about posterior mal, but there's a lot of classifications, and predominantly we use the St. Georgean classification. I think that the AO classification in the foot does not do justice to the significance of the injuries and some of the ligamentous type injuries. But this is a patient, 26-year-old motorcycle accident, adduction injury, midfoot swelling, but neurovascular intact, and they had a compression fracture of the articular surface, and sort of if you would think of this as a joint depression fracture in the calcaneus. So we fixed the articular surface, we bone grafted this, and then we're trying to preserve the talonavicular joint while we're establishing or restoring stability when this, and in this case, like a plateau fracture, bone grafting underneath it, there's a high risk of osteonecrosis or non-union, but really understand that if we can restore that talonavicular, immobilize it, and then start physical therapy after the healing, okay? This is a place where I'm a fan of early weight bearing, but not in these, okay? So this is something we protect them. And then we can delay a talonavicular arthrodesis if it's necessary. And so, again, I talked about St. Georgean classification. This is a medial column. Roy Sanders looked at these, and they were uniformly poor prognosis, whether they were fixed or not in the body. So moving distal, the Lisfranc injury, this is the most litigious area of complications in the foot. And we need to look at radiographs, and we have to assess this. When the radiographs are normal, then or undetectable, then we have to do stress films. We can do that by a simulated or a real weight-bearing film, but often CT is really important. What we can look for is alignment of these joints, and this is not a subtle film, but recognize that the medial second metatarsal to the middle cuneiform has to always be lined up. If that's unstable, then you've got an unstable Lisfranc injury. You can also look at the fourth, because that lines for the lateral column, but oftentimes these are not discernible in a stress view, and so we have to kind of decide based on swelling, based on that plantar ecchymosis, whether these are operative. And a lot of times I will do a stress under anesthesia with a consent to do a fixation. I've seen this enough times that where it's all things look stable, but there's that ecchymosis. And so understanding how we restore the anatomy, restore this is important. Using radiographic markers that we don't have, I don't use an intraoperative CT, I use a direct visualization approach. And once we can realign the varus and valgus on the sagittal alignment, we can look at our plantar flexion of the first ray, and then begin fixation. Fixation of these is a talk unto itself, but understanding that it is important to realize bridge plating has no improvement. And I used to use bridge plating a lot, and you'll see films. These are mine. I use it less, but a big screw across an articular surface is eroding a joint, and so it has to have another surgery afterwards, and that gives us the question of arthrodesis or not. So Coetzee and his partner looked at these in the classic study on non-bony injuries, looked at primary arthrodesis versus fixation. And when they compared these, there was improvement by an early fusions within non-bony injuries. I want that to be emphasized, because if there are fractures, then they can heal. And so Ramelt and others subsequently have looked at these and found really no differences. And the most recent study is from 2024, is a prospective trial that was randomized, and they were about 2 patients short of actually having sufficient sample size. So Do we buy it or not? They gave up after 10 years. But I think it's worth understanding that at least in Finland, there's no difference. So in my pitch and my practice, I tend to try, if they're younger, to restore the anatomy, and then we come back later if we have to fuse it. So the key points on these on the medial column are recognizing the injury, understand this medial column stability, and do a CT scan for a diagnosis is essential. Spanning fixation or transarticular fixation is preferred, and I don't always go to a direct fusion for these patients. Lateral column, very quickly. This is a person who had a cuboid fracture that was unstable and a dislocation. We plated it. We kept this plate in for 6 months. And then when we had stability, I took the plate out. They've got a restored arch, and they had a decent outcome. But again, this is an area where fixation but not fusion is an opportunity. These are often delayed recognition in polytraumas. We always prioritize and respect the soft tissues. And in the medial column, constituting from the talus all the way to the metatarsals, we need to have stability. And if that takes fusion because there's too many to count pieces, or there's articular damage beyond reconstruction, then fuse it. Again, if lateral column assessment is that there's subluxation or instability, if there's a collapse of the cuboid, fusion is then restore alignment and stability. Try to not fuse this side because patients generally do not tolerate articular surface or arthrodesis on the lateral column. So thank you.